Okay, thank you very much for having me. It's a pleasure to meet with Dr. Banerjee, Dr. Hazra. I'd like to thank Dr. Kumar and Dr. Banerjee for giving me this opportunity to speak here. So my topic is a little odd. My test with cardiac electrophysiology. So what I've done is I've just tried to show why my first love has been cardiac electrophysiology. As quite a few of you know, at the end of my tenure doing cardiology in India, I had got two fellowships, one to do interventional cardiology in England and do EP in the US. So I chose EP, right or wrong. Uh, I think my love is still going on. And we'll just talk a little bit as to what in EP is so interesting. So EP is one of those subjects that has developed tremendously. Almost every day there's something new coming out. So today I'll try to go through some of them, which keeps me still interested, and my love for EP increasing every day. So the good news is that almost 60% to 65% of patients in today's cardiology ultimately become EP's patient. I was hearing the interventional talk today. Uh, the news is quite a few of these interventional people ultimately become EP as they start developing AFib when they grow older, or because of intervention or bypass surgery, they develop heterogeneity in their myocardium, resulting in VT, heart failure. And that's why today in modern cardiology, almost 60-65% of patients, both for arrhythmia, congenital arrhythmias, and heart failure, become EP patients. And I think that's so important information that we as EP can serve this population. So it's a subspecialty of cardiology focused on diagnosing electrical activities. Of course, we do complex ablation, implantation of various cardiac devices. I'm going to go through a couple of them that came out in the last few years. And the most important part is it's vital for treating conditions that cannot be managed by medication alone. And we, thanks to development of science and technology, we can give a minimally invasive um, uh, opportunity rather than having an open surgery, which has its own mortality and morbidity. So as you guys all know, being cardiologists, there's a massive increase in the global burden of heart disease. Almost 32 to 35% population die in this planet due to cardiovascular disease alone. And the tragedy is the trend is rising despite massive increase in technology and also of cost. It is increasing. Certainly, it is increasing to a tremendous extent, both in developing and mid economies, but and somehow it tends to have plateaued a little bit, though there is some rise even in very highly developed economies. India, as you know, is going to be is already the diabetic capital of India, and so in 2025, it is projected that India will have more heart attacks than United States of America. So there are various records of the prevalence. I don't want to quote any data because it's not overall same for every state. Some states we have good data, some states we do not. But anyway, long story short, this is an overall picture which you can clearly see that Southeast Asia, which is predominantly India, Pakistan, and Bangladesh, but India having way more population, you can see there's a massive increase, and the increase continues to happen. And the tragedy is the risk is all through, whether it's environmental risk, more pollution, whether it's metabolic risk, more obesity, and behavioral risk. We'll just talk a little bit about that without wasting much time. So this is, as I said, India is going to beat America in 2025. It is believed, pundits have said, by having the largest number of heart attacks. We are already the diabetic capital of the world. But if you go through this slide, this shows one of the reasons. So as you can see, the data is not completely latest because we do not have the latest data from India. The latest data we have is from US in 2021. But the latest data of comparison we have is still 216. Tobacco remains to be way, way more in India than in the US, which is sad. All over the world, especially in developed country, tobacco use is coming down. Physical activity, as you can see, is still almost same. It was lower before. But look at the dietary risk. It's so sad that India is a country where we has to have a lot of plant diet, not large meat. But we are slowly aping the West, and whereas West is going for a plant diet, in less inflammatory food, we continue to have non. We continue to have large meat most of the times during the day and most of the days in the month. And that's one of the reasons, possibly inappropriate diet, poor lifestyle, increased stress, which causes this cardiovascular disease. If you look at the burden of health disease, the one on the top left is total cardiovascular disease. West Bengal, where we are having this conference, is unfortunately one of the highest, though the highest is maybe Tamil Nadu and Punjab. Obviously, the lifestyle explains, particularly in Punjab. But if you look at ischemic heart disease, Bengal is still higher up in the list, though not the highest. Other than the few places in the Deccan Plateau, which is low, Rajasthan and UP is low, but I think this is skewed because Rajasthan and Uttar Pradesh are large states with a lot of rustic village population. So this may be slightly skewed, whereas places like West Bengal has got shows more like, and it's a small state with more urban population. So I think the rate, that's why it may be skewed and looks higher. But I don't know. Same with stroke. Bengal, unfortunately, has one of the highest rates of stroke in India, and as you know, stroke, there's really no difference between stroke and cardiovascular disease. Only the territory is different. One is in the brain, the other is in the heart, but basically they are both vascular system diseases. Evolution and significance, it's one of the newest subspecialty of cardiology, EP. There's increased recognition and specialization worldwide with significant expertise still concentrated in the United States. Only a few places in the Europe, particularly Germany and Netherlands, have similar level of EP penetration. Even other advanced countries have not. One of the reason is cost. I think the same problem in India. We have super good doctors in India, but cost, unfortunately, has been a problem. So, wasting much time, I'll just talk about some of the diseases and what is the latest in the field, and that's where my tightest with with EP goes, because EP is one of those specialties where every day we have something new, and I'm really happy to state that. So atrial fibrillation, as you know, in 1999, we know that it comes from the veins in the pulmonary vein, and that's responsible for atrial fibrillation. Atrial fibrillation is a huge problem worldwide, with 43 million people. America has got 4 to 5 million. In the next 10 to 15 years, we expect that to go up to almost 50 million in America itself. In India, we do not have the exact data, but in India, there's a conundrum. The conundrum is that, unfortunately, AFib in India are of two types. One is secondary to rheumatic heart disease, which occurs in much younger population. And the second is non-valvular AFib, which is the commonest variety all over the world. But with increasing aging population in India, the second variety is also increasing by the days and the months. And a lot of my friends in India who practice EP in different states do tell me that. But there are a considerable number of rheumatic fever causing it. So we have been traditionally doing what we call the radio frequency ablation, basically, where we go inside the heart, we access from the femoral vein, go to the left atrium, make a double transeptal, go to the left atrium. We put a catheter in the coronary sinus so that we can pace. And then going into the left atrium, some people use single transeptal, some people use dual transeptal. And then using a single catheter, we ablate all around the pulmonary veins. Both sides of the veins are ablated. The advantage of this technique, rather than cryo, is that cryo, a lot of people uses, especially those who have not been trained in their fellowship, because it's easier to use. You can push in a balloon and your job is done. But cryo has been shown clearly does not have the same amount of success, particularly in chronic cases, than radio frequency, where you do point-to-point ablation. So this has been the staple food for most of us for a long time, and now we have moved to something that is quite different. That is called the PFA, where we use what we call a flower-shaped catheter, and we go inside the um, pulmonary veins, and we put the catheter astride each pulmonary vein. We deploy the flower, put it astride each veins, and then do ablation. The only thing is that this requires considerable expertise with intercardiac ultrasound. I personally take my intercardiac ultrasound into the left atrium so that I can see better. A lot of people do it from the right atrium itself. And we take it to the left atrium, and we have to see how the tissue is appropriately assessed by the flower so that you don't have any gaps and you can do ablation. So a couple advantage. One is you can finish a AFib maybe in 40, 45 minutes, and with thousands of AFib, that makes the EP schedule much better. You can do many more cases in a day. And the second thing is all the fear about about esophageal perforation is gone. As you know, esophageal perforation is a rare but a dreaded complication. Here you see the basket being pushed into the right superior pulmonary vein, and we use ice to make sure that there is appropriate apposition between the walls of the pulmonary vein and the flower catheter, and then we go ahead and ablate. So this is, we use thermal energy, so chance of esophageal perforation is less to almost none. And though esophageal perforation is rare, as you can know, even if it happens in one cases, the mortality is pretty high. And that's why I think this is a completely newer mode that has come into play. I will slowly shift gears to another important um, place where EP has played a very important role. We have over 26 million affected worldwide. That's 216 data. And now this is the data from India, also pretty old. I couldn't find more later data. Maybe it's there somewhere. Unfortunately, there's not much of data from large tracts of the country, including the Deccan Plateau and the Northeast states. But it's well imagined that heart failure is a huge problem in India also, and it's a growing problem. And now we have new entities like heart failure with preserved ejection fraction. So for the last 100 years, the treatment of heart failure has been pretty stable. In the last 10 to 15 years, we have new drugs. But as you know, despite using all the 4 or 5 pillars of cardiovascular drugs, despite that, the prognosis isn't good. Only a small percentage of people actually respond. And that's where these newer technologies have come into play. I'm going to talk about 3 different things that we do. The one is cardiac contractility modeling. This is something we did almost 1.5 to 2 years back. We'll talk a little bit about that. This is done in patients whose QRS is less than 130. That's they are not candidates for CRT, or they are candidates for CRT who have failed CRT. In those patients, we do EF can be between 25 to 45% with grade 3 New York Heart Association symptoms. Then we have the newest kid in the block called BAT, baroreflexor activation, where any EF below 35% can be done. Again, people who are candidates for CRT or LOT CRT, they do, in those cases, we do CRT or LOT CRT. But those who are not, they can be candidates for BAT. And it's important to understand that only 30% of patients have left bundle branch block and left QRS more than 150 milliseconds that makes them a candidate for CRT. That's a very small number. And we must not also forget, out of that 30% who are actual candidate, more than 30% fail CRT. So using I do not know the price in India. I'm said it is 12 to 14 lakhs, which is a huge amount of money. if the procedure is a failure, and we have quite a few failures here. And the good news here is it's covered by insurance. I'm not sure of the status in India. It's a tragedy. And that's where this newer can play a role, especially in people who you cannot give CRT or people who have failed CRT. You can use some of this new technique. I'll talk a little bit about phrenic nerve stimulation, and I'll explain why it looks like it's something totally different, but it's not. And it plays a very good role in chronic heart failure patient, and we'll talk a little bit about that shortly. So newer therapies in heart failure, one is subcutaneous ICD. I've just put the name here. Unfortunately, it's not new. We've been doing it for 6 years now, maybe a little more, 7 years now. So then we have the newest kid on the block called extravascular ICD. I'll talk about that. Cardiac modulation therapy, as I said, we did a couple of years back, and we continue to do that in selected patients. I'll talk about that. Barostim is the newest stuff that's being done. It's called the Barostim Neo system. I'll talk a little bit about that. And last but not least, I'll talk about Remedy. Remedy is used for sleep apnea. So why am I talking in a cardiovascular talk? I'm not a pulmonologist. Yes, because we are the doctors who do this study, who do this devices. Why do we do these devices? Because now it's clear that people with chronic heart failure develop CSA, central sleep apnea. And unlike what was thought before, central sleep apnea is a manifestation of heart failure. That is true. But what we now understand is progressive CSA actually worsens heart failure. So there's a vicious cycle between CSA and heart failure, which we did not understand till now. So if you do not treat CSA, which, as you know, is untreatable using the normal sleep apnea machines, because they only treat peripheral CSA. They don't treat central CSA, because central CSA is a problem in the DRG neurons in your midbrain and pons. So there's no known drug to mankind that can treat those diseases. So we use something called Remedy. I'll talk a little bit about that. And it has shown great effect. So subcutaneous ICD, I think it's been there for 6, 7 years now. I think the first case we did almost 7 years back. I don't spend much time on that. Basically here, what we do is we make two incision, one on the below the armpit, which is pretty large because it's a big device. And another incision nowadays we do just below the sternum. And then we put a lead, as you can see, next to the sternum. And then the main device is put next to just below the armpit, and we make a tunnel and we connect the lead with the main device. So some advantages is you can use in people who have had disease, who have had infection, um, and you cannot use intravascular ICDs in those places. But more importantly, you can also use in young people with a history of sudden cardiac death who you have resuscitated. Because remember, this can last for 10 to 15 years. And also you can use for congenital heart disease, because in a kid who's maybe a teenager in a QT syndrome, they don't have to get a device changed every 6 or 7 years, but the device may be changed once in 15 years, which makes it good. This is an old technology. I just wanted to show it so that you do. This is the newest technology, what we call extravascular ICD. In this technology, we go to the fascia that is below the sternal bone. So unlike the subcutaneous ICD, which is actually subcutaneous, both the lead and the subcutaneous. Here it is not subcutaneous. Here this snake-shaped lead is put in the fascia below the bone, manubrium sterna, in that plane, as you can see from the lateral view where it is put. So you basically dig into that space and then put the lead there, and the lead is connected to the actual device, which you can tunnel, as you can see. The good news is that this device is much smaller, unlike the subcutaneous ICD, which is a much larger device. Again, same advantage, lasts longer, no infection. People who have had infection, you can put one of these devices rather than putting in a intravascular device, which has got liability for infection. Cardiac contractility modulating, that is another kid on the block. As you know, as we have chronic heart failure, there is change in the genetics of chronic heart failure. We slowly tend to get back the fetal genes, and those fetal genes makes our heart a useless organ. They stop working, and the calcium transport is a problem leading to heart failure. So this device, we put it in a pocket on the right side, because left side is generally left free for putting in the leads, the ICD if the patient needs one. This device, we put it in the right ventricular septum, 3 centimeters from each other. The two leads are put. If you have an ICD, the ICD can be on the left side. We still don't have a ICD combined with a CCM, but it's in the trials now. Hopefully, in the next few years, we will have a combined device that has got both an ICD and CCM. So what it does, it releases electricity at 7.5 millivolts 5 times a day throughout 24 hours, which increases calcium delivery into the muscle cells. Not only that, animal studies and even human studies have shown there's complete change in the genetical programming of the heart from the fetal phenotype, which is predominant in heart failure patients. Slowly, they start developing the adult genotype, which all of us have, and the heart not only comes back to normal. A lot of our patients that we have done, actually, the first patient we did is a guy who couldn't walk from his attached bathroom, from his bed in his bedroom. He had heart failure for last 15 years. EF was 25%. He had a CRT put in a couple of years back. The CRT also failed. So we put a CCM. In 3 months, his EF came back to 40 to 45%. It's more than 1 year, almost 2 years now. Our first patient, his EF remains normal. So it does work. The only problem is we do not have any long-term data. So if you can understand a guy whose handicap is so much that he could not walk from within 4 feet from his bed to his bathroom, can now walk a couple of miles every day. So it's a tremendous development in technology that we can use for the massive number of heart failure patients with reduced ejection fraction. And the good news is that this is the first technique that we are seeing where we can actually make a genetical change. Other than gene therapy, which is still in its infancy, very much experimental. This is one of those few techniques we now know where the actual genetic shift occurs to back to adult gene, which is normal in humans from the fetal genotype. So that's a tremendous development. Barostim is the other devices we use. We use this for patients who have at least 35% cardiac EF, um, NIHA grade 2 or grade 3, not candidates for CRT. Those are the patients we use. Let's hear a little bit about Barostim.
That electrically stimulates carotid baroreceptors to improve the symptoms of heart failure. Baroreceptors play a critical role in maintaining cardiovascular homeostasis by simultaneously regulating the sympathetic and parasympathetic branches of the autonomic nervous system. Afferent signals from carotid baroreceptors are constantly transmitted to the brain to interpret. The brain uses these signals to regulate heart, kidney, and vascular function via the autonomic nervous system. Patients with heart failure have decreased signaling from baroreceptors, which results in an increase in sympathetic and a decrease in parasympathetic tone. This imbalance in the autonomic nervous system leads to worsening heart failure symptoms. Barostim is delivered through a small pulse generator and an extravascular carotid sinus lead. The system works through continuous electrical stimulation of carotid baroreceptors, increasing signaling to the brain, resulting in a decrease in sympathetic and an increase in parasympathetic tone. By restoring balance in the autonomic nervous system, Barostim has been shown to significantly improve patients' exercise capacity and quality of life.
So the advantage of these system is that they are more affordable than a CRT, and a wider number of patients will benefit. Almost 100% patients can benefit, because unfortunately, as I said, CRT is effective only in 30% of heart failure patients who have LBB, and even out of that 30%, almost 10% may not respond at all, and up to 20% may only partially respond to CRT without their EF becoming normal. But some of these newer technologies has made a rapid change in the life of heart failure patients, leading to massive improvement in their cardiac function. Again, the only problems that still remains is we do not have any long-term data. These are all cutting-edge technology that we have been using, and unfortunately, we do not have long-term data. For example, in CCM, the EF is improved within 3 months, but would that remain for 10 years, 15 years, 20 years? We don't know. Same with the Barostim. There has been improvement in cardiac function. There is exercise capacity improves, EF improves, but how long that's going to stay, we do not know.
Indranil, you're almost running out of time. We can
Okay.
conclude. Yeah.
Yeah, so Remedy is the other device, as I said, from CSA. In CSA, what we do is we remedy CSA causes heart failure. Heart failure causes more CSA, so it's a bilateral problem. Here we take the device and put it in the pericardiophrenic artery vein, as you can see, so that you stimulate you stimulate the phrenic nerve and you treat CSA. It can also be put in the brachiocephalic vein. So these are the new techniques that we have been using. So pacemaker implantation, again, a big problem. We have 20 to 30,000 pacemaker implantation in India. But pacemaker, the normal pacemaker has its own problem. It can cause infection. It reduces the capacity to use your left or right hand that is being implanted in. So now we have we have something called Micra many years now, almost 5, 6 years now. We have been implanting it, but for the first time now we have a dual chamber pacemaker that is leadless and can be implanted inside the heart. So this is the AVR system where we have two pacemakers, one for the atrium and one for the ventricle. We implant it's almost like Micra. We implant in the right ventricular septum. A particular technique needs to be used so that you don't go to the anterior or lateral wall, which will cause perforation, leading to pericardial effusion and tamponade. But following the technique, it's pretty highly successful, 98% successful. And in more than 95%, you will have synchrony. What it does is that you first take the two devices. One device goes to the right ventricular septum, and the second device goes to the right atrial appendage. Then there is synchrony between those two. They can see each other and then synchronize with each other, and so you get a normal pacing with synchronous pacing without having a physical lead. See, it's important to understand that there's a lot of young people who tend to have pacemaker nowadays for different reasons. During the short time I practiced in India, we also had people in Bengal, particularly having their pacemaker when they are 45, 50s. So these people are pretty young. They still have an active life. When you have a pacemaker that is physical, your movement of the hand, lifting weight, and those things are restricted. And those can be prevented if you have an intracardiac pacemaker that goes inside the heart. And these are retractable, so there is no lead complication, no chance of any infection, there's no chance of any pocket, no chance of any um, chest scarring. And the device implantation, as I said, is pretty easy. There's a short learning curve, which almost any cardiologist can pick up. In this country, unfortunately, only EPs are allowed to do it, but it can be basically done by most cardiologists. It's almost similar to doing a right ventricular cath. The part of the right atrium is a little tricky, but the one in the right ventricle is almost similar to what we do for Micra, which has been existing for over 7 years. And once it is put there, it stays. And at the end of 9, 10, 11 years, sometimes it can last for 12 years. which most normal pacemakers will not last that long. You can take it, you can extract it completely. So basically, benefits of interventional techniques. This is the reason why, as I said, my tirest with EP makes me a lover of the system till today. Is we treat more and more patients. Over 60-65% of the patients can get one of these. It is targeted treatment. You don't have to have medicine all your life. You don't have to. It's people are cured. They go home. The recovery is pretty short. Most of these patients are sent home the same day after the procedure, whether it's AFib, whether all these devices, we don't have to have any hospitalization whatsoever. The output is improved quality of life. As you know, cardiology is one of the system where there's maximum amount of trials. So there's been multiple trials on all this system before they're FDA approved. The challenges, of course, is limited availability of trained specialists. EP is a long training process. It takes 2 years after cardiology to train in EP. It's high cost. All these newer techniques does not come free. They come at a high price. And there are technical complexities. So a lot of practice is needed before these can be implanted without having complication. And some of them are directly inside the heart. So the complication can lead to cardiac tamponade and death. So that's important. Future trend is there'll be increased use of robotics and AI in electrophysiology. There is multi-billion dollars being spent by companies like Apple, Google to actually deduce people who will have myocardial infarction because we know there are changes in the body way before EKG detects myocardial infarction. Similarly, there are changes in the body before you have sudden cardiac death or atrial fibrillation, and those future trends is something that we'll be seeing in the next couple of days. The final goal will be broader access to interventional treatment and further reduction in arrhythmia-related complication. Thank you very much.
Thank you very much, Indranill. It's a great talk, really.